noises, so I do apologise. I've been teaching all day. So I was asked to talk briefly about the transfer of the cardiac patient. So Embrace, I believe you all know who Embrace are and what we are. The picture on the screen at the moment is a picture of where we're based at Embrace. So we're based just on the M1, halfway between Leeds and Sheffield PICUs, and that is what the building looks like. So we're based on an industrial estate. We have got multiple dedicated teams throughout the day, and we're sited at a central location. We have got lots of teams, lots of equipment, and lots of ambulances that we use for these transfers. I appreciate that you all help us at the stabilisation units where we go to collect these patients, and at Leeds you receive the patients from us, but this is just a little bit of how we get between the two. The staff that's used at Embrace, we're a combination of PICU and NICU nurses as a background. Within our service, we don't just work in paediatrics or neonates. We're a combined service, so we could be expected to go out for any patients, which means that the nurse bringing you the cardiac patient may be of PICU background, maybe from neonatal. We're all experienced in transport. We've all got training in neonatology if we're from a paediatric background. We've all passed our basic life skills, our NLSs, APLSs, EPLS courses. We do an amount of simulation training, and we complete education and competency frameworks by our education teams. So when we're coming out to move a cardiac patient, sorry, these pictures are a little bit old because they've got baby packs on them. But when we're coming out to move our patients, obviously, depending on the size of the baby and where we've previously been on a transfer, we'll either have a transport inc with us with our Hamilton on, or it might be a baby in a baby pod, depending on the size. All our kit comes with 6 infusion pumps, monitoring, suction, ventilators. Oh, sorry, it's clicking on its own. And our infusion pumps that we're still using the Alaris pumps, and we have guardrails built into them. And Prostin is within the guardrails that we use. When we're coming to move a patient from a DGH, if that's where they've delivered, to usually Leeds for cardiac, all the information that you need or might be signposted towards for a safe transfer by ourselves is on the Embrace website. The Embrace website's been revamped recently, and it's very user-friendly. Very user-friendly, and lots of links to take you to the right area. On there, for any DGHs, they'll find the guidelines for both neonatal, cardiac and paediatric critical care. There'll be information leaflets and hospital directions for both in and out of region. When we're coming to move a patient, it's a very, very stressful time for parents. And one thing we make sure is that they know where we're going. We provide them with hospital information. We provide them with phone numbers if mum isn't able to travel with us. We do have rules about how far post-surgery it is before we can transfer parents. If mum's just delivered and it's been a normal delivery, she has to be 24 hours post-delivery before she can be transferred by ourselves. And if the baby's been born by section, it has to be 72 hours. So at that point that we're moving the baby from mum and separating them, it's important that they've got ways of getting in touch with where we're taking them to and information on where we're going. Within our Embrace website, you'll also find information with regards to the STOP tool. The STOP tool stands for the Safe Transfer of Paediatric Patients. There's also time-critical transfer information and information about what Embrace might need from you. It's highly unlikely that Embrace won't be able to do the transfer, but during times when we're extremely busy or short-staffed, unfortunately, it might be important that the local team is aware of how they might have to do the transfer themselves, even if it's a cardiac baby. As I say, we would do our best to make sure we were available, but there might be that one chance when we're not. And this information on the website will lead you to be able to do the transfer yourselves and how to be able to do that safely. When a patient's referred for cardiac transfer, they come through the call centre. It's an acute referral that comes through. The call handlers will create the event. The consultants or registrar or ANP team will triage the patient. a team will be mobilised and they'll be sent out to where the patient is in order for them to be brought into Leeds. If you did have to do the transfer yourself, it would be a 999 ambulance that you'd have to request. Embrace has a single point phone number, which I've put on the screen there. The call centre is very busy at times. They know where cot and maternal beds are available if it was an IUT transfer. Obviously, if a cardiac patient, ideally, if they were delivering in Leeds, then Leeds would facilitate that. They're able to give clinical advice. We're able to organise transfers. And we're also able to organise recorded teleconferencing facilities with real-time recording of all calls. If the call came through at a point where they delivered in a DGH unexpectedly, we'd be able to facilitate them speaking to Leeds and the cardiology teams all on recorded line to enable the correct information to be passed along. The aim of transport, as somebody said earlier on, is moving the right child to the right at the right time with the right people to the right place. And with cardiac babies, it's important that they're ideally delivered at the place that's going to give them ongoing care. But as Joe was saying, there is a time and a place if they've decided not to continue with care that they might be delivering at a DGH, or they might unexpectedly deliver at a DGH and require transfer. In order to move that patient safely, we use an accept model. The patient's assessed, we work out how we're going to move them, we use communication, we evaluate the patient at the point we arrive, we prepare them and package them in the appropriate equipment, and then we move them safely using the transportation methods that we have. When we come out to a DGH to move the patient, we're always thinking ahead. We're always wondering what we need to do next. What could go wrong? We spend a lot of time, or the required amount of time, preparing that patient for transfer, so that once we get into the back of that ambulance, hopefully nothing will go wrong and we've prepared for every possibility that could happen. We use an Abcde approach to our stabilisation. We anticipate any problems, and we sometimes feel as though we demand a lot of the referring centre, expecting them to make up infusions, preparing extra infusions depending on the length of the journey, making sure that things are compatible, changing lines. That's one of the big things that aren't compatible between units. We spend the time at the bedside stabilising the patient and ensuring that the least things possible could go wrong during the transfer. We need to identify the nature of the illness, and obviously with these patients, the cardiac patients. The cardiac guidelines would be adhered to for depending on what condition they're presenting with and what rate of prosting that they would require. We're working out where we're going to and from, and obviously hopefully we're going to LGI, not further afield. We have to work out a route of how we're getting there and take into consideration the weather, the traffic conditions, and how we're going to transfer them. During any transfer, it's a difficult process at times, and it's very possible that this stabilisation of the child might not be so stable during the transfer process. We try to maintain the highest quality of care that we can during the transfer. In the back of an ambulance, it's not a nice, comfortable environment that most people think it will be. During the process, you've got acceleration and deceleration pressures. Rapid acceleration and deceleration can have a physiological effect on all of us, never mind the poor cardiac little neonates that we're moving. The effects are noted less in road ambulances than they are by air, and we do generally move these patients by road. But rapid braking and accelerating can have forces of up to 7G whilst we're in the process of being moved. We do attempt to move these patients as stably and as safely as we can, but we can't predict the manoeuvres of every road user on the road during the transfer. With cardiac patients, with the head travelling forward in the ambulance, the rapid acceleration and deceleration has an effect on the venous return and the cardiac output, depending on where we are in the process. And if the child has a failing heart, it could have a reduced output. So what can the referring centres do to help us at Embrace? Prepare any infusions using the Embrace drug chart and following out the ODN guidelines. You can use the stop tool, which I've got some images of in a moment. Embrace has created a neonatal and a paediatric transfer checklist, which has been issued to all DGHs. It's a green and yellow chart, which I'll show you in a moment. That helps them in the preparation of items that they might not have thought about for transfer. Name bands, maternal blood sample. Any patient that we're moving for any reason that's less than 3 months old requires a maternal blood sample to go with the patient. The maternal blood sample, usually taken by a midwife, it needs to be taken and labelled with a form as if it was going to their own blood bank for cross-match. These are a copy of the neonatal and paediatric transfer checklist that have been created, and all units should have received these. If not, please let us know and we'll make sure that we get them to you. Most places have put them up in their ED departments and also in their stabilisation rooms on their wards. And it just goes through what might be needed and what would help in us facilitating getting out the door a little bit quicker when we come to stabilise these patients. I mentioned the stop tool. I know it's probably a little bit difficult for you to see as on this small screen, but this stop tool, it's a 4-page guide which would lead you literally through every step of the process if you were required to move a patient yourself, whether it's cardiac or for any other reason. It's just going through Embrace's renowned for checklists, which we love, and it's just going through ensuring everything's copied and covered, and it's even got an observation chart there on the last page for you to use during the transfer process. Any questions?